Welcome to Roadmap to Residency. Hello everyone, I'm Abhiraj. Welcome to our Club 250 Mass Maker sessions. We are currently in our hematology oncology sessions. This is our last video. We will be running through a few questions with you guys to help you on your journey to 250. So what is the most likely cause of our splenomegaly and pancytopenia? A 28-year-old woman presents with fatigue, early satiety, and leftover quadrant discomfort. Physical examination reveals splenomegaly and lab tests show pancytopenia. Peripheral blood smear shows nucleated red blood cells, teardrop cells, and immature granulocytes. The patient denies any significant medical history or recent infections. What is the most likely cause of splenomegaly and pancytopenia? Infectious mononucleosis, chronic myeloid leukemia, autoimmune hemolytic anemia, hereditary spherocytosis, or myelofibrosis. So option A is infectious mononucleosis. So why infectious mononucleosis can cause splenomegaly? It typically presents with atypical lymphocytes and peripheral blood smear, not the nucleated red blood cells and teardrop cells seen in this case. Option B, a chronic myeloid leukemia can cause splenomegaly and pancytopenia, but the characteristic Philadelphia chromosome is not mentioned. Uh, the autoimmune hemolytic anemia may lead to splenomegaly due to the sequestration of antibody-coated red blood cells, but it does not typically cause pancytopenia. Hereditary spherocytosis is a hemolytic disorder characterized by spherocytes on peripheral blood smear. It is not associated with pancytopenia. Myelofibrosis is a proliferative disorder that can cause splenomegaly and pancytopenia and teardrop cells due to the bone marrow fibrosis. So the most likely cause of this patient is splenomegaly, pancytopenia, and characteristic blood smear findings is myelofibrosis. Now, this disorder is characterized by the deposition of fibrous tissue in the bone marrow, leading to impaired hematopoiesis and extramedullary hematopoiesis in the spleen. And the teardrop cells are a result of distorted bone marrow architecture. The condition may also be associated with constitutional symptoms such as fatigue and or satiety due to splenic enlargement. The clinical anatomy and physiology of the spleen. Let's discuss something about that. So the red pulp of spleen contains the cores of bilirubin with fixed macrophages and sinusoids. So the white pulp of a spleen contains B and T cells. The important functions include blood filtration. Macrophages remove hematopoietic elements like senescent red blood cells, intraerythrocytic parasites like malaria, and encapsulated bacteria like Streptococcus pneumoniae. The antigen trapping and processing in MPs will occur, and it is reserved for 1/3 of the peripheral blood-plated pool and the site for extramedullary hematopoiesis. So this is the overview of the anatomy of the spleen. So we have the splenic artery and splenic vein. This is the hilum, and then you can see we have the white pulp and the red pulp. So the red pulp, there is the capsule which is made of collagen, elastic, smooth muscle fibers, and mesothelium, and there is the stroma. Okay, the stroma contains the reticular cells and fibers. The white pulp contains the nodule containing the lymphocytes and antigen-presenting cell, and then there is the mantle zone, marginal zone, and this one is the perilymphoid red pulp. To the germinal center is there, and again we have the T cells and the central artery here inside the white pulp. So the histology is somewhat important for the spleen. We can you just remember that white pulp has this round structures, and the red pulp is just surrounding the white pulp. So the basic mechanisms and causes of splenomegaly. So the number one is work hypertrophy, which is caused by an increased immune response, and the examples may be infectious mononucleosis, subacute bacterial endocarditis, and malaria. The congestions examples include splenic venous thrombosis and portal hypertension. It may be due to RBC destruction, work hypertrophy, which may be due to hereditary spherocytosis, pyruvate kinase deficiency, and beta thalassemia major. The myeloproliferative disease may also be the cause, which may include polycythemia vera, myelofibrosis like in our patient, and essential thrombocythemia. The neoplastic disease may be due to acute and chronic leukemias and malignant lymphoma, or some infiltrative disease like primary and secondary amyloidosis, sarcoidosis, Gaucher disease, and Niemann-Pick disease. So the healthy spleen, the size is generally 12 centimeter. The enlarged spleen is size more than 12 centimeter and more than 400 gram. And massive splenomegaly is when the size is more than 20 centimeter and the weight is more than 1 kg. The causes may be, okay, so the most common causes are infections, cancers, and portal hypertension. The least common causes are hemolytic anemia, sickle cell disease, and chronic inflammatory diseases. And the rare causes include metabolic diseases. The symptoms are abdominal discomfort, decreased appetite, and symptoms of cytopenias, okay, like fatigue and dizziness. The signs of symptoms of underlying condition may also be there. Like if there is infection, the patient may have fever and chills. If there is cancer, the patient may have night sweats and weight loss. The treatment is focused on underlying cause, avoid sources of abdominal injury, and prevent the ruptured spleen. And we go for splenectomy and vaccination to reduce the infection risk against the capsulated organisms. So, hypersplenism is an exaggerated state of splenic function. RBCs, WBCs, and platelets, either singly or in combination, are sequestered and destroyed. So, the most common cause is portal hypertension associated with cirrhosis of liver. The clinical findings may be splenomegaly, peripheral blood cytopenias, and compensatory reactive bone marrow hyperplasia, which is the attempt by the bone marrow to replace the lost hematopoietic cells. And the correction of cytopenias is with splenomegaly, splenectomy. So always remember the question is asked something like when the patient has undergone splenectomy due to some reason and what is he at risk of. So he's at risk of developing pneumonia due to the encapsulated organisms like Streptococcus pneumoniae and all. So we need to vaccinate these people against those organisms. The spleen dysfunction and splenectomy. The signs of spleen dysfunction include whole jolly bodies. These are the nuclear remnants in the peripheral blood RBCs. With a functional spleen, the macrophages would have removed the RBCs with whole jolly bodies. But with an dysfunctional spleen, they are not able to remove that. The predisposition of infections by encapsulated organisms like Streptococcus pneumoniae, Haemophilus influenza, Salmonella Neisseria, which can cause septicemia, peritonitis, and osteomyelitis. So immunization helps to prevent against these organisms. The mechanisms causing infections by pathogens just listed are the concentration of IgM drops leading to a decrease in complement system activation. Splenic MPs are not present in sufficient numbers to phagocytose the opsonized encapsulated pathogens. So toxin is normally synthesized in the spleen is lost. So overview of the splenomegaly, the common causes are portal hypertension, cirrhosis, okay? The other causes include RBC. So those related with RBC are thalassemia, hereditary spherocytosis, okay? And there is so this is non-cirrhotic portal hypertension, okay, the NCPH. So there's malaria, babesia, or Roya fever. The WBC causes may include a mono like Epstein-Barr virus, CMV, and HIV, okay. The tick-borne like rickettsia, granuloma like tuberculosis. The myeloproliferative disorders like polycythemia vera, essential thrombocytopenia, myelofibrosis, CML, malignancy like lymphoma, leukemia, autoimmune like sarcoidosis, and some drug-induced hypersensitivity reactions. And there are some of the other causes like amyloidosis and lysosomal storage diseases, which can also cause splenomegaly. Thank you for watching. We will meet again in the next module.